Strokes per year, approximately 25% of people die. It's the 5th leading cause of death, but the biggest thing with stroke is it disables you. It causes life-altering deficits. It causes you to have to feed. It causes your family to fill your medications. It causes somebody to have to wipe you, and it causes disability, which not only impacts the patients, but it impacts every one of the caregivers who has to take care of these patients.
At 2:38 this morning, that they did transport somebody.
Wonder if they got TPA. Do you get names?
No, I don't.
We leave here, I can find out what they did with it. So who's at greater risk for stroke? African Americans, Hispanic, women, and anyone over age 65. Does anybody know why women have more strokes?
We have more stress.
Men! Men's the answer!
That's what I said, we have more stress because I was looking at this man over here.
Women live longer than men. So as you age, your risk of stroke increases. And so since women live longer than men, they have more strokes. There's also some hormonal components in there, birth control and hormone pills and patches that may be correlated with that, but age is the biggest one. Things that you cannot change is your age, your gender, your family history, and your race. You're stuck with that, nothing you can do about it. What you can do for stroke to prevent stroke is manage your blood pressure, manage your blood sugar, manage your heart rate and rhythm, be active, eat good food. We put on the slides, if you smoke, smoke less. This is Kentucky, and if you say quit smoking, people go, no, I don't have to do anymore, and they walk away. So if you smoke, smoke less, and if you avoid excessive alcohol. You may know what excessive
We
alcohol
had 3 strokes. 2 they transported.
Really? Wow. If you can get those names, give them to Linda, and she'll follow up with them and see if they got TPA or how quick they got
See if
TPA.
they actually stroke. I mean, we're paid
Sure.
that stroke.
Sure. Who knows what it actually is up to you?
But those 3 is.
Wow. Anybody know what excessive alcohol is?
Yeah, I guess so. I went up this. Because I would have fell off. Sure.
1 beer?
It's like 2 to 3 drinks, more than twice a week. 1 ounce of alcohol for females and 2 ounces of alcohol for males.
But I don't drink.
That's not very much at all.
Is that daily or weekly?
Daily. Per hour. Per hour. No, not per hour. Our first goal with stroke is to recognize a stroke. And so the FAST acronym is facial drooping, arm weakness, speech difficulty, and then time to call 911. So the FAST message is very important. We need to know this message. We need to share this message with our friends and family. We need to leave this message with our patients when we go into families or into homes. We need to leave it with the families of the patients, and we need to be speaking this. My son is 11. He watches Emergency, the old show from the 70s.
Yes,
we were watching it. And there was a patient that had a heart attack. And so he's sweating and he's holding his arm and he's the picture perfect heart attack. So that was in the 70s that everybody knew the signs and symptoms of heart attack. And we're almost to 2019 and only a third of the population know the FAST message. So we really need to be speaking this, and it's our duty to get the message out so that people will recognize when someone else is having a stroke. Don't go to bed. Don't go to bed. Don't let them go to bed. Don't let them say, I'm going to lay down to bed. You got to speak that message, because if you lay down and go to bed, you knock yourself out of the treatment window for a stroke treatment. Time is right. Everybody knows this. Everybody knows time's right. When you roll through the doors of the hospital starts on clock. Whatever hospital you're in, they should be giving TPA within 60 minutes from the time you roll through the door. So you should go directly to CT scan when you take patients into the hospital. You should be getting a scan, and they should be seeing the doctor, getting an assessment, and then getting TPA administered. And I'll talk about TPA in just a minute, within 60 minutes. So we're on a clock and we're trying to move fast in all hospitals. First place you want to go is to the CT scanner. And what you're looking for on a CT scan is there blood. That's the only thing you're looking for on a CT scan. If there is blood, then the patient is not eligible for the treatment options we're going to talk about. If you see dark area, this is an ischemic stroke that has happened between 6 and 24 hours from the image. It happened 6 to 24 hours ago. So you're already too late for treatment options if you see anything dark on CT scan. So when you go to the CT scanner, what you're looking for is a normal CT scan. How many of you all have heard in the hospital? Her CT was normal, they didn't have a stroke. Have I heard that? That's not true. That's not true. You're looking for a normal CT scan because you want the patients to get there quickly. You want their onset of symptoms to be less than 4.5 hours from when they arrive, and you want to see no damage on a CT scan. So there's two treatment options for stroke. The first treatment option is a clot busting medication called TPA. Who's heard of TPA? Okay. It's approved in 1996. So this is an old medication that we are giving for stroke. ED physicians are terrified of it. In 1996, they gave it to one patient who had a large vessel occlusion. That patient died right in front of them. They bled out and died. So now they're terrified. This medication is, we're picking the patients differently than we did in those studies. So it had a 6.4% bleed rate in the studies in 1996. Most stroke hospitals have a bleed rate of about 2%. So they're picking the right patients, they're managing their blood pressure's better, they're treating the patients differently now. So TPA, clot busting medication, it can only be given to patients up to 4.5 hours from their last known normal. 4.5 hours from their last known normal. So this is a patient that you don't want to drive to Lexington if you can get them here. If they're at the 4-hour mark, you don't want to knock them outside of that 4.5 hour window. So I guess what you all have previously been doing is anybody within a short window you were taking, and anybody in a longer window you were bringing here to the local hospital. Is that correct? We want to flip that. Anybody that has a last known normal of less than 4.5 hours needs to go to a local hospital, the closest hospital that can give TPA. Because the patient needs to be assessed for TPA and not taken outside of that window. So anybody that's in 4.5 hours onset of symptoms needs to get TPA quickly. Every 15-minute delay, TPA is approximately 1 month of disability. I don't want to be the one responsible for causing 4 months of disability to get to Lexington on a patient. I don't want to be the one to make that decision. The second treatment option is for a smaller number of patients, probably 10% of patients, and this is clot retrieval or thrombectomy. They go into the colon, needle wires, and stick a spring in there, pull out a blood clot. This is determined if they're going to use this by doing what's called a perfusion scan. A perfusion scan shows if there's any brain that can be salvaged. It shows any brain that's thirsty, that if you remove that clot, it will get reoxygenated. Show you what our actual perfusion scans look like, and then I'll go back to patients. So this is what a perfusion scan looks like. This little tiny purple is what's called cord infarct. So that's what's already dead. There's nothing you can do to save it. Doesn't matter what happens to it. It's dead, and it's going to stay dead. All of this green is what's called a penumbra. That's thirsty area around the cord infarct. So this is the same image as this, but this is dead, and this is just thirsty. So if you pull that clot, you can save this half of the brain. Does that make sense? Okay, so this is our first patient. This is a 57-year-old, history of diabetes, hypertension, coronary artery disease. All of those we just talked about are risk factors. Patient has no drug allergy, and a sudden onset of right-sided weakness and aphasia. Who knows what aphasia is? Tell me about it.
Like when you can't correlate your thoughts towards.
Good job. Good job. It's, you know what the word is, but you can't get it out. So this is the thing you drink out of, the thing you sit in. You can't come up with cup or chair. The words are in your brain, but you can't get them out of your mouth, and that's aphasia. The other speech difficulty that you look for on the FAST is slurred speech or dysarthria. And what that means is that the muscles of your face and your tongue won't let the words come out clearly. So you can think of the words and you can say the words, but then you slur them because of your muscles in your face. So those are the two speech difficulties you're looking for. Patient's blood pressure is 125/85, regular pulse at 80, stats at 96, temp normal, and was 120 kilograms. So blood pressure to give TPA has to be below 185, below 110. below 185, below 110 to give TPA. So what that means is get the patient's blood pressure down and then give TPA. It doesn't mean, oh, they have a high pressure, we're not going to treat it. It means get down quickly, and then treat it. Once you get their blood pressure down and you give them TPA, you have to manage their blood pressure between below 180, below 105. So it's a pretty tight parameter to get them down under. You all won't be treating blood pressures in the field unless you're transporting from the hospital to Lexington with a patient that you're managing their blood pressure on. You'll likely have a nurse if you've got a cardiac drip. Is that true? Then you'll likely have a nurse if you have a blood pressure drip.
No, we take a look.
You all manage cardiacs? Good. Wow.
We can administer metoprolol if the blood pressure's over a certain range.
You all do you all titrate drips, or do they have to be?
We can and right, yeah.
We have an order we can titrate.
Good for you. Good for you. Nobody's using nitro, are they? Treat blood pressure.
Yeah.
You don't talk them into chest pain. That used to be a thing. Your pressure was high. Aren't you in chest pain? Are you sure you're in chest pain? Let's get that down. So SATs, patients don't need to be on oxygen unless their SATs are below 94%. And then this patient's 120 kilograms. So TPA is a weight-based medication that has a maximum dose of 90 milligrams. So this patient's going to get the full maximum dose. TPA is a one-time medication. It's 0.9 milligrams per kilogram with a max dose of 90. And you give a bolus of 10%, and then you give a drip over an hour. So this patient will get 90 milligrams. So your bolus will be 9 milligrams, and then your drip will be 81 milligrams that will go in over 1 hour. So it's one-time dose. You don't repeat it. So this guy arrived at 12:50 was last known normal. Called EMS. EMS brought him to the hospital at 13:58. They called us at that time. Patient got to the door at 14:18. Glucose was 388. Went to CT scan 3 minutes later. And then let me talk about all these pieces here. Door time is when our clock starts. Glucose was 388. Who knows why we care what glucose is? Good job. Stroke mimics. If the patient has a low blood glucose, they can present as a stroke. So if you can give them a half empty 50 and make them better,